Before we dive into the conversation, wanted to let you know that I'm Mary Minetti. I work as a Senior Policy and Program Specialist and will be moderating today's conversation. I also have with me my cohorts, Annette Lee. Annette, are you going to show your face and say hi to everyone? Annette is our Healthcare Program and Communication Specialist, and she is the person who keeps all this technology running. So I really appreciate her participation. Annette, did you want to say anything?
No.
Okay.
I don't have much to say.
So if for some reason you are having some difficulty with your technology, we encourage you to message Annette through the chat, and that would be, it would get to her if you choose IPFCC in the list of all the different participants who are involved. Pam Dardis, our Vice President of Strategic Initiatives and Operations, will be joining us. I don't know that she's joined us yet. She had a conflicting call that ended right before this was to start, and knowing how calls go, she may be joining us just a little bit late. But I want to go ahead and get started out of respect for your time. Annette, do you want to go ahead and go to the next slides? I just want to set the stage about our virtual conversation. I encourage those of you that can to chat in your name and your organization. I know that Ben from the Indian Health Services Office of Quality Improvement Patient Care has chatted in his name and organization. He was the first one. Thanks, Ben. We're going to use some polls to learn about those of you on the call, and our goal is to learn from each other. And the conversation will be recorded, and it'll be placed in the PFCC Connect space, learning space, in a folder called Health Literacy with the main community. And we'll load additional resources onto that Health Literacy folder at the end of the time that we're together. It's always helpful for us to see who's on the call and just have a quick poll. So Annette, if you want to pull up that poll while I'm kind of talking about the goals of the informal discussion. So one of the things that we really want to be clear about is that this is not a us presenting information to you, although we'll set the stage, but it's really you sharing with each other what you're learning about efforts that you're making in your organization related to health literacy. So if you can fill out the poll that's currently up, which is what is your current role at your organization? It's always nice to know whether we have folks who represent different practices, hospital leaders, patient and family advisors, and others. And Annette will let us know when we've had enough response to the poll that we can close it and see, what's the mix of the people that we currently have on the call. I know that we, and a number of you are chatting in, we have 38 people who've called in. That's a lot of people, which suggests to me that we've got a lot of interest in this particular topic. And I know, having just recently done a specific health literacy conversation for the PCPCC network, there just is a lot of conversation around how to communicate in ways that are useful and meaningful to others. And it looks like we have a pretty, we have a lot of others. 50% don't have the current roles that we have listed. So for those of you that might not have other roles, you're welcome to chat in what those roles are. We've got a pretty even mix of patient and family advisors, clinical leaders and administrators, physicians, coordinators, and patient experience folks. And we're glad all of you are here. We really appreciate that. If you want to go ahead and switch to the next poll, it's important to understand that patients experience care across the continuum, and how we address health literacy in the primary care setting is as important as how we address health literacy in the community and in other settings such as hospitals. If you want to just take a quick moment to indicate which healthcare setting you work for or work in, either as patient and family advisors or in other roles, we'd love to see what that is. that may drive where we're spending most of the time in our conversation, although you really are the group that is going to drive what's most important. So, Annette, if you want to take a look at how much response we've had to the poll. And it looks like a majority of individuals on the call are representing hospital and medical centers, although we have mixes in other areas as well. And ambulatory and specialty care often can be housed in hospital facilities. So we look forward to a conversation by all of you. So if you want to go ahead and really quickly go to the next slide. So I want to make sure that we're all on the same page, and this is the common definition that is used to describe what health literacy is. It's really the ability of people to navigate the healthcare system and make the decisions they need in partnership with their healthcare providers by being able to understand basic health information and being able not only to understand it, but to process it, to find it in different ways, and ultimately it's for the purpose of maintaining or improving their health. Next slide. It's a big problem, and as you can see, these are the key attributes of health literacy. So it's what's in the written flyers, in materials that we provide. It's in terms of how can people look at documents that you might provide to them and be able to fill them out and understand what the documents are asking. It can be quantitative things. How well are they able to read pharmacy labels and understand what a milligram is, what it means to take it twice a day. It's also how do we talk directly with people in the oral language. And also now with the advent of the internet and so many people utilizing the internet through patient portals or for other reasons to search for information, that's another component of health literacy. Next slide. Annette. And what I would just say is 36% of the population, which is over a third, has basic or below health literacy skills. It's higher for certain populations, but most of what we care about is impacted by health literacy. We care about, if we're receiving the care, we care about our outcomes and the quality of care that we care about, but we also are interested in being able to understand about the costs and services, and sometimes health literacy, low health literacy, it is related to unnecessary costs and services. And ultimately, next slide, Annette, 9 out of 10 US adults have some difficulty in using everyday health information, in maybe not in all of those arenas, from oral to numerical to prose, but in some arena where everyday health information is available, both in our facilities, but in retail outlets and media, the newspaper, on the internet, and in our communities. So we really do need to pay attention to it, and that's why so many of you are very interested in this conversation. So if you want to go to the next slide. So I want to know what you're doing to address health literacy in your organization, and that may guide where we go with our conversation, because people will be interested in being able to see that. And so you can check as many of these things that you are doing to address health literacy in your organization as possible. And if you choose other, then you can type into the chat what that is. Using screening tools, using TeachBack, adopting only health education materials that are 5th or 6th grade reading level, inviting advisors to create educational materials or review ones that you have for plain language, and how are you engaging staff by providing health literacy education so that everyone working in healthcare understands what an important issue this is as it relates to delivering patient and family-centered care. Because if we don't deliver useful and affirming information that people can act on, then we really have a big missing piece in delivering truly a patient and family-centered care system. So Annette, if you want to see how our response to the poll is going. Okay. So it looks like a great majority are adopting health education materials that are at the 5th and 6th grade level and using TeachBack to actually check in to make sure that we communicated in ways that people could understand and make sense of, and inviting patient and family advisors. So I am interested in going to the next slide because it helps us understand what you were interested in having a conversation about. And these are the key areas that I'm going to open up for discussion. People are interested in knowing what kinds of tools people are using, what resources there are, how they're assessing their organization's strength, how they're creating buy-in, how they're addressing and engaging the needs of unique populations, and how they're engaging patient and family advisors in their approaches and initiatives. So I'm going to open up the conversation and ask that anyone is welcome to start by sharing what you're doing. A number of you are choosing materials that are at the 5th or 6th grade reading level, and that might be a good place to start. What kinds of tools are you finding? And for those of you that are on mute, you're welcome to take yourselves off mute if you want to share some thoughts and ideas. We certainly don't want to prevent anyone from being able to participate in the conversation. So I see that Donna's on the line. And Donna, I know that you had indicated that you were doing some unique things in your organization. Would you like to start off the conversation, talk about what you guys are doing?
Sure, thanks, Mary. Good afternoon, everyone. I'm very fortunate to be on a couple of different patient family-centered care groups and have seen some really exciting things over the past few years. Let me just share an example. We have what I call a super senior on one of our PFACs, and she was just amazing. She could pick up a document, whether or not it was wound care or C. diff or sepsis. She could quickly pick up that document and just amazingly could pick out all of the complicated explanations and come up with wonderful examples of how to streamline and simplify some of the verbiage on the document. So I call her a super senior because she does it with such ease. It's amazing. And if any of you who have been involved in healthcare, as I have been in the past, what I find is that it's a little more difficult for me to sort through some of the nomenclature. But I have to say that she's just amazing. And I would encourage everybody to, if you do have documentation that's going out to your members or to your patients or to your patient's family, that you test this. Test it with all of your PFAC members, because some of them just have tremendous skill to pick these things up. Secondly, we're in another group, we're expanding the ethnicity, and particularly with Hispanic members. What we found is that engaging with our Hispanic members, we've learned so much about just different foods that they eat, things that we wouldn't normally, I say we, things that I know I wouldn't normally think of, but in the Spanish community is more palatable and more appealing to the Hispanic environment. And it was very helpful. She was amazing to help us get into some of those communities where we could do some education and some training, and just offers a huge variety of suggestions for the Hispanic community. So we know that language can be a barrier, and we know that dealing with medications can also be a barrier. So we have spent a significant amount of time looking at the outpatient documentation, and specifically around medications. And that's an ongoing activity for us. One of the, I'm sorry, Mary.
Great. Donna, you've mentioned a lot of things, and I want to follow up and see what others might want to contribute as well. You've clearly thought about cultural competencies and how to engage populations that you wouldn't normally engage, and how you can have individuals look at documents that we may find very accessible and realize that we haven't put them in plain language. And I noticed, Cheryl Chadwick, you've mentioned that you guys have a robust health literacy committee. And I was wondering if you wanted to chat for a minute about how you integrate your patient and family advisors into that, and how it relates to some of the comments that Donna has made in terms of working with populations other than English speaking or from different cultures.
Sure. So just a test. Can you hear me?
Just barely. You might get a little closer to the microphone.
Okay, I'm trying to figure. I'm actually in my car. So can you hear me now?
I can.
Okay, I'll talk loud. So Children's Mercy does have a robust health literacy committee that was started like over 11 years ago. I am a paid parent on staff, so I sit on that committee. It's a multidisciplinary committee, and we use our different patient family advisory councils. We now have 17 of them to send out and review documents. We do have a group, El Consejo de Familias Latinas Hispanas, which is our Spanish-speaking advisory council that can give us input on, they like a lot of times check the translations to see if what they are reading makes sense to them. Our health literacy committee, we've also created education that we've taken hospital-wide, and we have a health literacy 101 class that is an hour class. Then we've developed a health literacy 102 class, and it is just like that step above that gets into items like numeracy that focuses a little bit more in depth. We also created health literacy advocates within our organization, where our nursing staff can earn points by being a health literacy advocate. We send them quarterly expectations where they have to do like education assignments, if you will, and then take it out to their units and then report back to us what they have done.
Great. Sounds like you're really engaging your staff through education to become more aware. And how does that translate in terms of changes in the way care is delivered, do you think?
Well, first of all, the Health Literacy Committee also our intranet has a way that any staff member can send a document to the Health Literacy Committee for ideas on how to reduce the reading level on that. And so that's one committee within the Health Literacy Committee. So they also, we've also rolled out TeachBack, which is part of our Health Literacy 101 education, so that the expectations are that every provider uses TeachBack to confirm the patient and family's understanding of their instructions.
Great, great. I noticed that Kathleen White, you mentioned that you're using universal precautions, not necessarily one kind of assessment, and that you see health literacy as an accessibility issue. Are you in a position where you can speak to the group and tell us a little bit more about that?
Yes, can you hear me?
I can, thank you.
Okay, thank you so much. So one of the key things that we have had to decide as an organization is, were we going to try to take a step to measure the health literacy of individual patients that we serve or not? And I guess just that really the implementation hurdle to do that was too great. It's really hard to get real estate within our EPIC system to ask additional questions when our admission assessment, for example, is already very lengthy. And so we have chosen to take, when the literature started talking more about universal precautions, it made sense to us to think about viewing this from a universal precaution standpoint instead of thinking about measuring the individual. So I'm hearing a lot of feedback.
Yeah, I am too. The first thing I'm going to ask is if you are talking on the phone, if you can turn off your computer speakers, that sometimes is the first way that we get feedback. And then the other is for people to put themselves on mute who aren't speaking. who can take themselves off mute when they want to contribute something. So.
Okay, well, let's see if that works better. I did actually turn the speaker off.
Perfect. That's great.
So let me just give this quick example because I think this is what made it make sense to me. So Universal Precautions says that we're going to treat every person that we encounter as though they may have health literacy challenges, which is generally true if we're talking about 9 out of 10 people not having proficient health literacy. Then we need to expect that most people that we encounter are going to need some kind of help. It's just a matter of figuring out what kind of help they need. Maybe they need help with the numeracy. Maybe they need help with terminology. And so what we are advocating in our organization is a universal precautions approach rather than spending time, in essence, measuring each individual. So here's the example. An example would be that when people come into our organization, we don't sort of stand at the door and assess what their mobility is. We don't say, well, we have this many people today who walked in the door who need crutches or who have a cane or who came in a wheelchair. Although mobility is really important, right? But we don't stop and measure it. We know that we're always working toward increased mobility, but we don't measure it, and we don't measure our success as an organization by how many people we had coming in wheelchairs and walking out walking, right? In the same kind of way, I think it's helpful to think about health literacy in this way. We're not going to measure every person who comes in, but our goal is always to try to help people to be able to gain better understanding. And so we do that in practical ways by making our materials as understandable as possible, by opting for video education wherever we possibly can instead of only using print education, by incorporating TeachBack with every encounter. Those are just some examples of how we're trying to really make it a broad spread approach that assumes everyone may need help.
Mm-hmm. Great, great. And I noticed in the chat that both Jennifer Pierce and Pam Dardis linked to some resources and tools related to those universal precautions and some of those things. I'm wondering, Troy, you co-lead a citizens group, and so you're working in the general community and with the general community. Did you want to? You put quite a bit in the chat already that people can follow, but I'm wondering if you wanted to comment about the effort that you're making on a community-wide level around engaging people in this issue.
Sure. Our efforts are province-wide, so they're we've bitten off quite a chunk. So we sometimes wonder how that's going to go long-term. But the approach is similar to the conversation around universal precautions. We believe that all citizens in the province will be able to engage better in shared decision-making if they understand how our systems work. So our first piece of content was around just healthcare basics, around who are the players, what's publicly funded, what's privately funded, that sort of thing. And from there, we're going to be tackling how do I navigate, how do I advocate for myself, and what are my rights. So those will be the modules to come. But we're just pausing a bit to evaluate what we've already published, to get some community feedback and to really understand the cultural appropriateness of what we've designed. It doesn't have video. We know that's a gap. It doesn't have translations yet. We know that's another step. But yeah, just to see how it's landing with new users across the province.
Mm-hmm. So it sounds like it's a fairly new effort in that you know that there are some things that you'll need to do to really enhance that and to be able to engage populations who don't have English as a first language.
Yeah, it's a broad, I guess, comparable in the U.S. to a statewide, so province-wide effort that is got the major players, our health quality groups, our health authority, the universities, some of our community organizations that serve immigrant and refugee populations. So they've been the guiding force as we sort of move forward and tackle what content to publish. Yeah, it wasn't, we started about 3 years ago, so there's a lot of groundbreaking just in terms of culture shift first. So yeah.
Great. Is there a link that you could put in chat that shows some of what you've created, or is it not?
I've put it in the chat. It's called Healthcare 101, and we've published it on
perfect.
Where our personal health portals reside as well.
Lovely. Thank you, Troy.
Yeah.
So I'm interested in the issue, and there were a number of people interested in the issue of creating buy-in, both in the hospital setting and in other places. And what were some initial steps that people had in their organizations to create programs and policies related to this? Is there someone who has been working on these implementation issues and have some strategies that you would like to share? I don't have anyone in particular to call on, but we have a lot of people on the line, and I'm guessing that all of you, besides being interested in this conversation, have been doing some things in your own backyards. Anyone like to share?
Mary, this
Yes.
is Cindy Brown from ARC. Can you hear me okay?
I can. Thank you.
I have talked to a lot of organizations across the country who work on health literacy, and if you like, it's not my direct personal experience, but I can speak to some of the ways in which I've seen organizations do this.
Please.
Would that be helpful? Okay.
Yes, I think that would be helpful.
So the first is sometimes people attach it to another content area that they're working on. So for example, there was a health system in New York where it was really part of their health equity piece. And so bringing it together with health equity in an office of health equity and health literacy gave health literacy more attention, because that particular system was focusing on health equity, and they also worked together on language assistance, which was an issue, and there's an overlap issue between the cultural competence and the health literacy work. Another organization was all about patient safety. And so they integrated health literacy into their patient safety activities. So they made the argument that, you know, if we are going to achieve our goals for patient safety, we've got to first stress health literacy. And so their initiative, which was called Do No Harm, they were training throughout the entire organization on Do No Harm. Well, Do No Harm then had a piece on health literacy in it. So different approaches. I don't want to monopolize the conversation.
What I really love about ththose examples, Cindy, and I appreciate you sharing them, is that that they look at what people are already working on, and they don't see it as a separate thing, but they really integrate it in the fabric of the things that the organization has identified as strategic priorities, whether it's safety or health equity, and really integrate it into the fabric of the way that they approach addressing any issue. And I think that's a very powerful way to create buy-in.
So I would say kind of two approaches, though. One, I've dubbed catch a moving train, which is, you know, something's going on in the agency, let's hook health literacy onto that train that's leaving the station. And that was kind of the Do No Harm example. But another organization did the real integration piece that I think that you're talking about, Mary, which is they established 3 big goals for their health system, and one of them was around patient engagement. and they drilled down and realized that health literacy really needed to be part of that patient engagement. And so health literacy became part of their strategic planning and all of their activities. They tried to weave the health literacy in there as part of their overall work. So I think that's a better one. That's a better example of what you're talking about.
Great. And I noticed that people are very active in the chat in terms of identifying some tools that people can use as part of implementing those universal precautions. And so I want to just remind people that you're certainly welcome to copy and paste those right now, but we will also save the entire chat with those links and put those into the PFCC Connect folder on health literacy. And for those of you that have additional resources and perhaps can't quickly get them into the chat, we want to encourage you to go out to PFCC Connect or send them to Annette Lee and she can load them into that. A number of you have indicated that you work with or are patient and family advisors working with organizations. And I'm wondering if you would like to share for those of the audience who in the conversation who perhaps haven't engaged patient and family advisors in those health literacy efforts. If you could share how you've done that, where you've started, so that they get a sense of the how-to of creating that strong partnership. Does anyone want to chat about that? I know, Cheryl, you've done that at Children's Mercy. And Lori Albers, I don't know if you're on the call, but you're with Children's Hospital of Wisconsin, and your work is around family engagement. So I'm guessing that you have some strategies as well to share. I'm wondering if one of you is on mute, but maybe talking without us being able to hear. Or is there someone else that's worked with patients?
Mary, this is Cheryl.
Oh, okay, great. Hi, Cheryl.
Hi. So one of the things at Children's Mercy is we've tried to engage patient and families advisors that are actually have healthcare experience with whatever's being written about. So like, for example, we have used our teen advisory boards to review literature that is written for teens. We've discovered that it's difficult for mothers to write information that their teenagers will read. And so our teen advisory board have written a lot of documents or proofread and then gave us suggestions for documents on teen type topics like STDs, violence in teenage relationships, and just some of those teen type topics that we actually go to those people who have had that experience, and then they can read that document from their perspective and let us know whether or not, we're hitting the nail on the head and in a way that that they can understand it.
Great. That's wonderful. Other comments or strategies that others have used related to engaging patients and families? I love that you were thinking about bringing people who have a lived experience about something or have an interest in that, understanding that topic to the table.
Hi, Mary. This is Angela Miney at UF Health in Florida.
Hi, Angela.
Hi, how are you? And
Great.
We on our PFAC, we have developed a very nice relationship with our infectious disease folks who regularly bring documents to the PFAC to ask us to review them. And it's interesting because one of the things that is often raised are the photographs or the pictures that people are using or that have been proposed. And we have regularly said, can you simplify those or, make them not so scary looking, especially around, various things connected with infectious disease. So that's just one of the things that stands out for us.
Great. And when you provide that, when you provide the infectious disease department or any other department with feedback, do they bring back to you their next iteration so that you can see how your feedback has been incorporated? I know for some advisors, knowing that their feedback has been meaningfully utilized can be very helpful in keeping them engaged.
Yes, I would say we do. I mean, they are one department that regularly come to us, and but with most of the things that the PFAC are engaged in, we kind of remind our leadership every so often to come back and, you know, report back on, just kind of close the loop on what has happened with some of the suggestions that we've made. So yes, they have come back and shown us the updated documents.
Great, great. Well, thank you for sharing that. It's really useful to know. When a department begins to develop and build a relationship with a PFAC and sees them as a resource, I think that that's a really good indication that the partnership is strong and and that value is being achieved on both, you know, in both arenas. So that's a great example. Angela, thank you so much. Do others have other examples related to, and I do want to let you know that there's all kinds of great key tools and resources being loaded by Cindy and others. So I encourage you to take a look at those. But are there other things that people are doing? This whole issue of cultural competency and health literacy is one that organizations sometimes are challenged with. Does anyone on the call have some experience with that particular topic and have things that they want to share?
Hi, this is Jennifer Pierce. Can you hear me?
I can, Jennifer. Thank you for joining the conversation.
Oh, my pleasure. So I am I'm a health literacy I call myself a practitioner in that I help health systems to implement health literacy principles. And Cindy Brock's advice, I just want to mention that she gave earlier, was advice she gave to me many years ago, and I want to say it works. I was able to effectively link health literacy to an existing priority within the health system I was employed at, and it took off and really gained traction. So I just wanted to provide a testimonial for that piece of advice. But to the question you're asking, one of the challenges is with health literacy materials or health literate materials is once you have them developed, for example, in English, to the level you're targeting. Oftentimes organizations simply hire a translation agency to translate them to the variety of languages they're looking to reach, and that's a problem. You can't stop there, because the reality is, just because it's health literate, easy to understand, actionable, and readable in English doesn't mean it is all of those things in the other language. And so I would caution groups to really engage folks, clinicians and patients and family members who speak that language, to review the material, because that understanding is in the eye of the beholder. And we found, even working with very highly skilled translation agencies, that they didn't necessarily end up moving the needle as far as we needed to. And it really took that added patient piece to come back and say, that's the wrong word for pattern, I guess. And I'll give you an example. We translated one document to Farsi, and the translation agency used pattern as you would if you were sewing a dress, like a dress pattern, rather than the word for a pattern that would relate to sleep pattern. No one would have caught that, and the health system would have looked um, less than professional putting that out. So just another, don't cut it short. Use the same principles you would to co-develop materials in English as you would for any other language.
Great, Jennifer, that's a wonderful reminder, and it also speaks again to the importance of engaging all populations that are served in your efforts to make sure that the information is usable and actionable and makes sense within the culture that it's been translated into. So I thank you for that. I noticed Cindy has mentioned and linked to some cultural competence related to the National Class Blueprint. Do you want to say anything more about that, Cindy? You may be on mute or you have nothing else to add to that, but I appreciate you adding it into the chat. Donna, you are talking about your chief hospitalist attending your PFAC meetings. Did you want to share any more related to what's been an outcome of that related to health literacy practices in your organization?
Sure. They've been extraordinarily responsive to our requests to simplify the communications that we have with patients, and again, to help in the clarity of some information that they're in the process of delivering. In addition, they're very responsive to listening to any concerns that the PFAC has. And I'm not sure whether or not this is routine through several PFACs, but I can tell you that our chief hospitalist is excellent and listens very closely, as do any of the members. We also sit on committees within the hospital, and our committees are at the point where they're requesting that they have PFAC members attend, because the value has, they've seen the value of the individual contributions from our PFAC members, especially with regard to health literacy, the empathy and the compassion, as well as the understanding.
Great. That generally is a good success sign when you've moved beyond the PFAC and you're actually integrating patient and family advisors into ongoing committees. It's a both-and world. It's good to have both a PFAC and integration on committees. I'm wondering if there are other questions that people who are on the line, maybe on the line to learn some things, and I may not have asked the right questions of some of the individuals we have who have lived experience related to working with health literacy. And are there any questions that people want to chat in or ask of this group? We have 37 people who are passionate about this subject and have a variety of interests, learning interests and things. Any questions? And remember, you may be on mute, so you'll want to double check that so that we can hear your question if you have it. Cindy, I see your mouth moving, but I'm not hearing anything. Did you want to get off mute and talk with us? For some reason you can't? Oh, I'm sorry. Well, we'll just have to rely on you to chat in some more great stuff. Anyone else?
Hello?
Yes.
Hi, can you hear me?
I can.
Great. This is Debbie Kovach, and I am a PFAC member at Suburban Hospital in Bethesda, Maryland.
Hi, Debbie.
My main interest was, or is, should say is, in really anyone's experience with the special needs population. I have a special needs brother who has had several hospitalizations, and he's on the autistic spectrum disorder, but fortunately is able to communicate, but does have some limits in his understanding of information and material. Are you receiving all of this that I'm saying?
Yes.
Oh, great. I just want to make sure it was coming through.
Yeah, I can hear you very well.
Yeah, and so our family members serve as his advocate when he's been in the hospital. Unfortunately, we've been able to be there, but what we experienced was an awareness that a lot of the clinicians and staff are unaware, perhaps, of the status or the limits or abilities of special needs. Often there's an assumption that the individual cannot communicate. And so my interest has been in trying to find out what is being done to enhance communication with special needs individuals, so it's a win-win for the patients and the staff, because an advocate can't be in a hospital environment 24/7.
Mm-hmm.
And to help staff to meet the needs of the patient, they need the education, they need the awareness. And I may be wrong, but I just see this as an area that has been perhaps ignored, not recognized as, it has not become, as I see it, a priority. And I have a very big concern about this from a personal and professional experience. I'm also a stress management instructor. Mm-hmm. And so this poses a lot of stresses on a family and a patient when communication needs cannot be met. So I'm wondering if there are others who are part of this conference call who have any experience in this area.
It's a great question, so let's pose it to our group. Is there anyone that's done some work in their hospital? Cheryl, I'm thinking about Children's Mercy in particular. You've been a leader in many areas. I don't know if this is one of them that you might want to comment on, or there may be someone else on the phone that wants to share.
You know, this is Cheryl from Children's Mercy. The thing that we hear from parents is trying to educate the staff to understand that even though some of their children may not be able to communicate, that they can understand. And so to educate that staff to remember to talk to the patient and not make those assumptions, and to gather that information from the family when they're first doing their assessment about the patient's abilities. As far as education for our patients with special needs, I can't say that we've done a lot of work in that area, but it sure makes me think a lot, and I absolutely agree that it's something that we need to take a look at.
Mm-hmm.
Oh, good. I think this has been a need, kind of a need, and maybe probably when there's only a crisis, does it then become a priority, and maybe by numbers, because I mean, my brother is an adult. He's actually a senior. You know, he's 60 plus years old. And probably because, as I say, if there were more patients, you know, in hospital showing up, that perhaps then this would become a priority. But I personally feel it, you know, we talk about literacy, and for special needs groups, you know, the blind, hard of hearing, the elderly, and I just have never heard of, in that whole grouping of needs, I have not heard about the say autism spectrum disorder or people with other disabilities. I don't see them being included. And in this day and age, that's not right. That's not right. This is a group that really needs, like any other group, special language needs. I mean, this group should be included with all others.
So
is what I'm saying.
Yes, and it sounds like it's an area that perhaps not a lot of us have experience with, and so Nancy has chatted in that she agrees, and she's just wondering if there are any tools for communicating with different populations with special needs. And I encourage anyone that has something to contribute to chat in. The other thing that I might encourage you to do is go out to PFCC Connect and ask that question to the larger community. We've got 30-some people on this particular conversation, but there are many more as part of the larger network who may not have been able to join. And you could raise that question and see if there are others that could share what they're doing in their particular settings. And I wonder also if it might be a question that you could pose to Suburban about what they are hoping to accomplish or share from your perspective and your brother's perspective, what might be some ways that could assist, because you're in a unique position as a member of the PFAC to raise issues that may have gaps. That's really the power of the PFAC, is to respectfully raise issues where healthcare has fallen short and help them think through how to address that issue.
Well, thank you for that, because when I heard about the Connect, I immediately thought, gee, this would be a great way to reach a large group of people on this issue. And also, just so you and everyone knows, I have raised this issue of concern at, with the PFAC and the hospital.
Great.
And was, and I need to follow up on that. And I'm intending on doing that, in the near future.
Great.
So it's one of those things where, you broach it, but then you want to keep on it and see what can be done.
So,
hey, Mary,
thank you.
Mary, this is Donna. I'd like to just jump in because certainly it's an area of concern. I think too, though, especially when I was taking care of my elder mom, it was important for me, and I understand it's difficult that you can't be there 24 hours a day, but having an advocate with an individual is so important in a hospital environment, especially when you have, in my case, an elderly mom. And I think your suggestion of how to educate the individuals while you are there, if you can't be there or can't have someone with him 24 hours, how can an individual communicate with the patient themselves is going to be very, very helpful and beneficial. So I want to thank this lady for bringing the point up.
Yeah, it's an important point. And I noticed that there's a lot going on in chat. For instance, Angela mentions that at UF Health, they've just invited a parent of a young adult with autism to join the PFAC. And she also is a family leader with the Deafblind Collaborative. And so, so part of it is reaching out to the communities that perhaps there are gaps that exist and bringing them in so that those stories and that information and the lived experience can be shared in a way that together they can figure out what might be able to happen. And I noticed that Troy has shared some training templates, and Cindy had raised a question earlier related to if anyone's working on health literacy and informed consent. And Jennifer, you mentioned that that you are. Can you just in a moment or two just share exactly what that looks like or where people could get more information?
Certainly. Two of the projects I'm working on, well, one is at the University of California, San Francisco, and there's a new common rule that requires informed consents now have a very concise plain language summary at the top, so that people can get really the gist of what it is they're being asked to decide on and evaluate and potentially agree to. So that's one project. And the other one is part of California's Whole Person Care Pilot Program, and it's working with individuals that have complex needs. And I'm doing some work with Healthcare for the Homeless, where I'm training their patient advisory council to evaluate content for health literacy, for readability, understandability, and actionability. And then they're helping to review patient experience surveys as well as universal authorization or county consent forms to ensure that people feel like they actually have a choice and can understand what it is they're being asked to agree to. So kind of two different approaches. One's more research-based and the other is very community-focused, but it's a huge area of need for health literacy.
Great. And I see that Cindy, our resource guru, has also shared AHRQ Making Informed Consent training module as well for people that want to learn more about it. And of course, you can certainly contact Jennifer if you need more information. I would love to continue this conversation for hours because we clearly have passionate people. However, we had committed to ending it in an hour, and I want to just kind of wrap up with a couple slides of information that may have been mentioned before. So Annette, if you're ready to move the slides along. For those of you that might not have joined PFCC Connect but heard about this informal conversation in a different way, we really would love for you to join it. It's free. It's an ongoing online learning community around advancing partnerships with patients and families so that we can transform care. So consider that if you aren't a member. Next slide, Annette. It's been mentioned a number of times about the AHRQ health literacy tools, and they have a quick start guide, and so we have information about that included in these slides that will be loaded on PFCC Connect, and of course they've been put into the chat. Next slide. You never know who's going to join these conversations, so I wanted to be sure to give a plug for AHRQ. There also are some additional health literacy resources with the North Carolina Program on Health Literacy, and they have some really nice teach-back videos about what it looks like when you are in a respectful way trying to get feedback about how well we communicated. And so I encourage you to check that out. Next slide. And then ACP has created patient and family-centered resources using principles of patient education and a number of self-management guides that exist. So for those of you that may not have a large education department, but you want to reach out and build on the power of community, you might be interested in checking out the ACP family-centered resources. Go ahead and next slide so we can wrap up on time. And they have a number of fact sheets as well. So they have a guide on diabetes and some other self-management resources, but they also have patient fact sheets and some DVDs. And patients are involved in reviewing all of these resources as well as working with health literacy specialists and plain language specialists. Next slide. I think we're wrapping up here. Oh, and then the CAPS does, for those of you that want to get feedback through a formalized process, they do have a number of questions that can be utilized. I wouldn't suggest you use all 31 of them. That might be overwhelming. But to pull some where you're working on a particular area to see if your universal precautions has really made a difference in how people are communicating and people are understanding, you might consider taking a look at those. And I think that is the last slide of resources, although we will get the chat with all these great other resources into our PFCC Connect folder. And we also have identified a couple recently selected articles that will load there as well. I want to go ahead and kind of end the workshop with the last slide that just says, thank you very much for joining. I appreciate all of you for either listening to learn or actively participating and sharing what you're doing. I feel like I'm better informed about some of the great stuff that's happening out there. And we really strongly believe that as a community, we can learn together and kind of raise boats for everyone, or the tide, or whatever is that saying. But anyway, I hope you guys have a great rest of your day, and you will be getting a follow-up email from Annette with the recording, so that if you want to share it with others in your organization, we encourage you to do so. So have a great evening, and for those of you on the East Coast, and thank you so much for joining. Take care.